merupakan rangkaian webinar dari seminar glaukoma yang keempat, yang pada hari ini bekerja sama dengan Perdami Sumatera Barat. Sunday with Glaucoma hari ini mengambil topik tentang Management of Glaucoma Patient in COVID era. Okay, we would like to welcome Prof. Naris Kitnarong from Thailand and Dr. Astrianda from Jakarta as a speaker. We are very honored to have you both as a speaker in this webinar today. Baik, saya akan bacakan susunan acaranya. Kita akan mulai jam 9 ini dengan opening speech dari Dr. Fitratul Ilahi, dilanjutkan dengan Dr. Firna, kemudian dilanjutkan dengan sesi ilmiah. Yang pertama adalah Dr. Astrianda dengan topik Patient Safety, Challenges, and Lesson Learned of Glaucoma Practice in Pandemic Era, serta Prof. Naris akan berbicara 2 topik secara berurutan langsung, tentang experience managing glaucoma clinic in Thailand during COVID era, serta glaucoma management. Masing-masing topik sekitar 20-30 menit. Kemudian sesi diskusi dilakukan di akhir presentasi pembicara. Untuk pertanyaan-pertanyaan dapat ditulis di kolom chat box. Baik, untuk acara yang pertama adalah sambutan dari Dr. Fitratul Ilahi. Pada Dr. Fitratul, kami persilakan.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi teman sejawat semuanya. Puji syukur kita panjatkan terlebih dahulu kehadirat Allah Subhanahu wa taala karena berkat rahmat hidayah serta nikmat kesehatan yang selalu dicurahkan bagi kita semua. Selawat dan salam kita sampaikan kepada Nabi besar Muhammad SAW. Yang sama-sama kita hormati Ketua Indonesia Glaucoma Society, Dr. Firna Dwi Oktariana, Guru Besar, teman sejawat, dan istimewa pada hari ini pembicara kita Prof. Naris Kitnarong dari Mahidol University, Thailand, dan Dr. Astrianda Suryono dari Universitas Indonesia, dan juga spesial untuk Dr. Elsa Gustianti yang akan memoderatori acara kita ini sampai akhir nanti. Izinkan kami dari panitia menyampaikan ucapan terima kasih atas kesediaan dari narasumber pada acara webinar ini, di mana acara ini merupakan kegiatan IGS dengan Perdami Sumbar, dengan harapan melalui diskusi kita pada hari ini akan menambah wawasan kita bagaimana kita melakukan manajemen pasien glaukoma selama pandemi ini masih berlangsung, sehingga kita masih tetap bisa mencegah progresivitas yang terus berlanjut dari pasien-pasien glaukoma. Juga ucapan terima kasih untuk tim ilmiah seminar glaukoma, sponsor, dan juga tim IT dari Kulon yang telah bekerja sama sehingga acara ini dapat terlaksana. Especially to Prof. Naris, I would like to express my experience, my appreciation to you as a speaker today. This webinar is collaboration between Indonesia Glaucoma Society and Perdami of West Sumatra. We hope that your experience in Thailand can be something we can do in Indonesia to manage our patient, especially glaucoma patient, during this pandemic. As we know that the pandemic make us change, and including changing the way to treat our patient. And I hope we have a great time join in this webinar. Selamat mengikuti dan semoga kita bisa mendapatkan sesuatu yang berharga dalam acara kita pada pagi ini. Dan terakhir, salam sehat selalu untuk teman sejawat dimanapun berada. Mungkin demikian yang bisa saya sampaikan. Saya kembalikan ke moderator. Saya akhiri. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr. Fitratul. Baik, kita sambung dengan sambutan yang kedua dari Ketua Seminar Perdami, Dr. Firna Dwi Oktariana. Silakan Dr. Firna.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, good morning everyone. Yang saya hormati para guru besar, teman sejawat, Dr. Mata di seluruh Indonesia. Terima kasih atas kehadirannya pada acara webinar Indonesian Glaucoma Society hari ini, kami mengangkat topik seperti yang tadi sudah disampaikan Dr. Fitratul terkait dengan manajemen glaukoma di COVID era. Mudah-mudahan materi yang dibawakan kali ini bisa membantu kita menangani pasien dengan lebih baik dan hati-hati agar kita terjaga kesehatannya, juga pasien kita juga terjaga kesehatannya. Terima kasih banyak saya ucapkan kepada Dr. Astrianda yang sudah bersedia memberikan presentasinya, dan juga Prof. Naris. Thank you, Prof. Naris, for your time to give a talk in our symposium. So we will very grateful to hear from you, and we hope we could collaborate more in the future. Terima kasih banyak semuanya. Saya kembalikan lagi kepada Dr. Elsa. Mudah-mudahan kita semua bisa menikmati simposium ini dengan sebaik-baiknya dan mendapatkan ilmu yang cukup buat kita semua untuk menjalankan praktik kita sebagai dokter mata saat ini. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih Dr. Firna. Baiklah para peserta webinar, kita masuk saja ke acara presentasi yang pertama dari Dr. Astrianda Nadia Suryono. Akan saya bacakan kurikulum vitae-nya. Dr. Astrianda adalah dosen di Fakultas Kedokteran UI yang telah menyelesaikan masternya tahun 2004, kemudian menyelesaikan fellowship glaukomanya tahun 2012 di National University Singapura, kemudian dilanjutkan di Moorfield Eye Hospital London, serta merupakan member dari berbagai organisasi mulai dari Perdami, APJS, APIO, dan European Glaucoma Society. Kepada Dr. Astrianda, kami persilahkan.
Baik. Terima kasih introduction-nya Dr. Elsa. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi kepada para profesor, pada para dokter dan rekan-rekan sejawat yang saya cintai. Terima kasih untuk Dr. Fitratul dan seluruh panitia di IJS Sumatera Barat, juga kepada Dr. Firna yang telah memberikan kesempatan ini. Jadi pada kesempatan ini saya akan bicara tentang glaukoma praktis saat pandemi dan bagaimana patient safety serta safety untuk tenaga kesehatan, apa yang sudah kita pelajari dan yang masih challenging di institusi kami. Professor Kitnarong, please allow me to speak in bahasa. So kita akan sedikit kilas balik. Jadi sebetulnya kondisi pandemik ini sudah terjadi sejak ditemukannya kasus pertama di Cina di akhir tahun 2019, di mana yang kasus-kasus pertama yang masuk ke Indonesia sudah mulai ada di awal Maret. Dan karena ini adalah situasi pandemi yang global, maka di berbagai negara sudah berlaku lockdown, bahkan sudah ada yang berhenti lockdown, lalu lockdown kembali, serta banyak protokol yang diharuskan, yaitu memakai masker, physical distancing, pemakaian face shield, bekerja dari rumah, sekolah dari rumah, dan ini semua akan tentunya mempengaruhi pekerjaan kita sebagai dokter secara umum ataupun ahli glaukoma yang harus melaksanakan praktek klinik glaukoma. Karena apa ini menjadi sulit? Karena sebetulnya kondisi ocular emergency dan urgency ini tidak stop dengan adanya pandemi, sehingga pasien-pasien kita tetap ada, tetapi kita harus membatasi gerak kita atau pekerjaan kita sehari-hari. Dan untuk itu kita penting sekali memikirkan safety measures untuk kita selaku pelaku kesehatan, provider kesehatan, dan juga pasien tentunya untuk terhindar dari infeksi. Sebelum kita masuk pada rekomendasi atau guidelines yang sudah ada, maka saya sedikit tampilkan kondisi situasi COVID di Indonesia sampai dengan hari ini. Ini barangkali graf yang diambil pada link government.go.id ini di bulan Juli ya. Jadi kondisi saat ini Jakarta masih menduduki peringkat pertama. Barangkali dulu pernah sempat Jawa Timur yang tertinggi, tetapi saat ini kembali Jakarta lagi yang tertinggi. Dengan kalau tidak salah terbaru adalah di Indonesia ini kasusnya per hari new casesnya mencapai 5.000. Jadi kita saat ini sedang meningkat lagi dan belum ada tanda-tanda untuk menjadi flat kurvanya ataupun menurun. Berbagai rekomendasi yang sudah ada dari institusi besar di dunia seperti dari American Academy of Ophthalmology, dan ini adalah salah satu guidelines juga yang saya kutip di sini yang cukup baik adalah dari All India Ophthalmology Society, dapat diakses dari link-link tersebut. Dan secara umum rekomendasi besar ini menekankan adalah satu, untuk pasien kita harus menurunkan jumlah pasien yang datang ke outpatient klinik kita dan melakukan triase ataupun screening awal yang mengecek atau mengetahui apakah ada faktor risiko tertularnya atau pasien ini infected oleh COVID-19. Apabila salah satu dari faktor risiko ini terdeteksi secara anamnesis, maka pasien mungkin bisa kita rujuk dahulu ke center atau ke unit yang menangani khusus kasus COVID. Di sini adalah hal-hal yang penting adalah apakah pasien tersebut ada kontak dengan pasien yang sudah terdeteksi positif ataupun ada riwayat traveling. Kemudian untuk surgery kita juga melakukan pemilahan pasien, tidak lagi semua kasus bisa kita operasi, kita harus lakukan pemilahan dari level urgensinya, dan setiap pasien yang dipastikan akan menjalani operasi harus melalui berbagai protokol yang lebih banyak daripada protokol pre-op sebelumnya, yaitu antara lain adalah screening untuk COVID ini. Dan secara umum dalam pelayanan sehari-hari kita menekankan pasien untuk selalu memakai masker dan face shield dan physical distancing yang berlaku juga untuk pengantar pasien. Kemudian untuk kita sendiri sebagai tenaga kesehatan juga sangat penting karena kita tahu kolega kita banyak terinfeksi, banyak kematian juga di antara kita, dan ini sangat tentu saja membuat kita concern. Maka kita harus mengingatkan lagi untuk selalu memakai APD yang sesuai dengan area tempat kita bekerja. Kemudian pada saat kita memeriksa pasien juga melakukannya secara minimal, waktu yang minimal, tidak terlalu berkepanjangan. Kemudian juga pasien biasanya kita memperbolehkan pengantar yang datang lebih banyak dari satu orang, tetapi saat ini kita harus lebih strict. Dan ini tentunya untuk mencegah adanya crowding atau penumpukan pasien, penumpukan orang di satu area tertentu. Jadi di area waiting room, di area lobby, di area semua area yang ada di rumah sakit ini harus kita cegah terjadinya penumpukan pasien. Dengan demikian tentu saja kita mengurangi jumlah pasien yang boleh datang di klinik kita per harinya. Kemudian kalau kita secara umum di bidang glaukoma ini banyak melakukan tes, satu pasien bisa melakukan 2 atau 3 tes dalam sekali kedatangan, maka kita perlu pikirkan untuk hanya melakukan satu tes, ini juga untuk satu tes untuk per kali kedatangan, ini tentunya untuk mengurangi crowding juga, dan selalu untuk tenaga kesehatan yang bertugas membersihkan area kerja kita selalu harus menggunakan proteksi yang tepat. Di RSCM Kirana, reaksi kita terhadap pandemi ini pada awal kejadian, yaitu di bulan Maret, adalah kita mengurangi pasien secara strict untuk hanya melihat pasien-pasien post-op dan pasien-pasien urgent serta emergent. Ini informasi ini kita buat dalam poster dan dalam berbagai media komunikasi yang disebarkan juga di berbagai social media ataupun media komunikasi yang ada di lingkungan RSCM. Kemudian kita juga menyediakan hotline Kirana, dan untuk pelayanan subspesialis tertentu atau hampir semua barangkali kita mempunyai nomor khusus yang dioperasikan oleh residen kita, sehingga pasien-pasien lama yang tidak bisa datang akan bisa berkomunikasi soal pengobatannya atau rencana ke depannya dengan lebih spesifik ke divisi atau ke subspesialis yang terkait. Ini adalah beberapa foto, jadi kita membuat suatu stop di lobi untuk melakukan triase yang akan dibantu oleh perawat juga, melakukan anamnesis dan survei form yang khusus tentang COVID-19 ini, dan dilakukan penapisan di bawah. Apabila pasien ternyata non-emergent atau non-urgent case, maka pasien sudah bisa diselesaikan di lobi tanpa harus masuk ke dalam gedung atau ke atas, di mana di situ akan ada pelayanan subspesialis. Ini adalah rekomendasi dari Perdami yang terangkum dalam satu buku panduan pelayanan kesehatan mata. Sebentar lagi akan di-launch, jadi saat ini masih dalam tahap akhir editing. Dan di sini sudah lengkap sekali terdapat guidelines yang mengadaptasi berbagai guidelines besar juga. Dari subspesialis glaukoma, kita membuat list of diagnosis atau kondisi apa saja yang kita sudah urutkan berdasarkan stratifikasi prioritasnya. Dari subspesialis lain juga ada list diagnosis ini, jadi nanti apabila sudah keluar pedoman ini akan sangat bermanfaat harapannya. Dan di situ juga kita bisa melihat bagaimana untuk pengaplikasian teleoftalmologi pada masing-masing diagnosis tersebut. Di sini bisa dilihat ada grading priority stratification, di mana glaukoma akut sudah tertutup, hifema traumatik, novaskular glaukoma, glaukoma maligna ini menjadi prioritas utama karena di sini dikatakan bisa menyebabkan permanent blindness dalam waktu 3 bulan atau kurang. Ya, jadi bisa dibaca nanti bahwa kita menggolongkan diagnosis-diagnosis ini berdasarkan bagaimana kondisi mengancam kebutaannya, ya. Kemudian jadi dari preferred practice yang ada di guidelines ini secara umum menyatakan bahwa pemeriksaan kita harus kita harus menyesuaikan pemeriksaan rutin yang biasa kita kerjakan dengan kondisi saat ini. Untuk pengukuran tekanan intraokular dari berbagai sumber dikatakan kita sebaiknya mencegah penggunaan NCT karena di sini ada mikroaerosol yang bisa menyebabkan resiko terkontaminasinya area sekitar dengan virus apabila pasien tersebut ternyata lolos dari screening kita dan pasien ini mempunyai infeksi COVID. Jadi sementara untuk pemeriksaan lainnya kita di-encourage untuk selalu menggunakan disposable apabila memungkinkan, antara lain yaitu untuk penggunaan applanation tape dari Boltzmann tonometer, eye care probe, tonoplan sleeves. Kemudian untuk gonioscopic examination dapat dilakukan dan ini secara umum tadi kita pemeriksaan slit lamp dianjurkan untuk menggunakan breath shield atau suatu penapis yang memisahkan antara kita dan pasien, ya. Dan gonioscopic examination dapat dilakukan dan pembersihan gonio lens ini diharapkan lebih rutin. Selesai satu pasien dilakukan gonioskopi, maka lensa tersebut harus segera dicuci. Kemudian untuk fundus evaluation kita di sini tidak menganjurkan atau mereka dari guidelines ini tidak menganjurkan direct ophthalmoscope, ya, karena jaraknya yang terlalu dekat. Untuk pasien-pasien yang sudah ketahuan ada COVID, maka yang bisa dianjurkan adalah dengan indirect ophthalmoscope, dan untuk yang paling aman adalah dengan slit lamp menggunakan condensing lens atau fundus fotografi. Kemudian untuk tes glaukoma yang biasa kita kerjakan pada pasien-pasien kita, maka disarankan dari guidelines ini untuk melakukan satu tes pada setiap kedatangan. Untuk Humphrey Field test ini kita harus perhatikan bahwa penerapan sanitizing pada bowl perimetrinya ini tidak mudah. Oleh sebab itu sebetulnya dibatasi hanya untuk pasien-pasien yang baru untuk me-establish diagnosis glaukoma atau pasien-pasien yang akan di-planning dan akan mengalami perubahan manajemen ini untuk mengurangi angka yang pasien yang harus melakukan tes Humphrey karena pembersihan dari bowl ini yang kurang begitu bisa yakin bersih. Pasien yang menjalani tes Humphrey ini harus menggunakan 3-ply mask, surgical mask, dan di tape bagian nasalnya, serta jika memungkinkan tap-based perimetry ini akan lebih baik. Kemudian OCT dikatakan imaging test ini lebih preferable daripada pemeriksaan Humphrey karena tesnya yang lebih cepat dan easier sanitation untuk alat-alat OCT-nya. Sehingga ini semua dapat meminimalkan risiko cross-contamination. UBM tidak dilakukan secara rutin dan memang hanya dikerjakan apabila sangat perlu dan harus digunakan gloves atau handscoon untuk operatornya dan menggunakan disposable tips untuk probe-nya. Kemudian bagaimana untuk laser dan surgery? Tindakan laser di sini tidak terlalu dikhawatirkan karena tidak ada atau minimal risk of contamination, jadi dapat diputuskan perlu atau tidaknya based on kondisi klinis dan judgment dari oftalmologisnya. Lensanya perlu disanitasi sesuai peraturan dan menggunakan breath shields pada saat melakukan laser, dan pasien menggunakan masker. Kemudian untuk surgery, nah ini yang harus di screen berdasarkan level of urgency dan emergency-nya. Dan itu semua dipulangkan kembali kepada surgeon dan bagaimana kebijakan yang diterapkan di daerah tersebut ataupun di rumah sakit tersebut. Disarankan untuk tidak melakukan dengan general anesthesia dan apabila ada pilihan, maka dipilih suatu operasi yang tidak membutuhkan atau lebih sedikit membutuhkan follow up post operatifnya. Jadi sesedikit mungkin kita harus melihat pasien post op, itu lebih preferable. Nah, ini adalah sedikit gambaran bagaimana situasi COVID di RSCM Kirana. Kita bisa lihat di sini pada outpatient clinic secara umum maupun di divisi atau di klinik glaukoma mengalami penurunan yang tajam di bulan April, ya. Sudah mulai menurun di Maret karena memang kasus pertama waktu itu di minggu pertama Maret. Sebelumnya barangkali di era pra pandemi di Januari Februari ini masih sekitar 7.000 per bulan pasien kita di Kirana, dan ini kemudian drop menjadi 1/7-nya atau bahkan lebih di bulan April, menjadi sekitar 900-an di bulan April. Demikian juga jadi kurvanya atau trennya ini sama di outpatient clinic dan di glaukoma klinik. Dan bisa dilihat di sini di bulan Juni sudah mulai agak naik lagi, ini kurang lebih sama bersamaan dengan waktu PSBB mulai direlaksasi dan bisa kembali sedikit kembali dengan new normal, dan semenjak Juni sampai sekarang kurang lebih sama dengan range barangkali pasien 2.000 sampai 4.000 per bulan di seluruh Kirana. Bagaimana dengan number of surgeries atau jumlah operasi? Nah, ini karena kita mengikuti protokol dan semua anjuran guidelines yang ada saat itu, maka banyak sekali mengalami pengurangan di bulan Maret dan terlihat sekali di bulan April. Dan ini secara dramatis sejak di pertengahan Maret diberlakukan PSBB di negara kita. Glaukoma surgery juga memperlihatkan pattern yang sama. Bagaimana jika ditinjau dari jenis tindakan yang dipilih atau yang dilakukan pada pasien-pasien di era pra-pandemi dan during pandemi. Secara umum dapat dilihat di sini bahwa kasus yang atau tipe surgery yang dilakukan didominasi oleh vakoemulsifikasi, ya, dan ini mengalami penurunan yang cukup besar, mencapai separuhnya di bulan-bulan berikutnya di masa pandemi. Secara umum average per month-nya menjadi 50% dari average per month-nya kondisi sebelum pandemi. Demikian juga untuk operasi-operasi glaukoma yang umumnya sebelum pandemi ini yang terbanyak adalah GDD, glaukoma implan, dan setelah pandemi glaukoma implan ini turun di peringkat ketiga dan lebih banyak trabekulektomi, tetapi secara umum dua-duanya menurun. Dan yang juga banyak berkurang adalah apabila masa pra-pandemi ini micropulse menempati urutan keempat terbanyak, masih menjadi keempat terbanyak di masa pandemi, dan ini turun cukup banyak menjadi sekitar 60%. Barangkali di sini kasus-kasusnya adalah kasus-kasus yang poor vision atau poor prognosis vision, sehingga tidak menjadi urgensi lagi untuk dilakukan di masa pandemi. Kemudian ini sebetulnya tabel yang sama untuk menunjukkan bagaimana penurunan pasien kita di kamar operasi. Tapi saya mau memperlihatkan di sini mungkin lebih kelihatan di sini betapa drop atau curamnya penurunan kasus-kasus operasi dan di bulan April, dan sedikit mulai meningkat di bulan Juni, dan tetapi masih tetap di bawah normal. Kalau kita tinjau berdasarkan diagnosis, maka kasus-kasus yang masih kita lakukan operasi adalah terutama yang termasuk dalam spektrum angle closure, dan khususnya adalah acute angle. Jadi kalau dilihat dari grafiknya di sini, angle closure cases, baik yang AAC maupun AACG, itu kurvanya tidak terlalu curam anjloknya, tidak seperti pada kondisi yang kronik ACG. Karena memang ini masih hitungan urgent dan emergent, tentunya kita tidak bisa mengurangi tindakan yang dibutuhkan apabila pasien datang dengan akut angle closure atau angle closure glaukoma. Jadi yang warna hijau di sini bisa dilihat dari grafik bahwa tidak terlalu curam menurun. Sementara yang kronik kita bisa tunda, jadi di saat bulan April ini sangat turun. Nah, kasus kedua terbanyak adalah juga secondary glaukoma, dan di sini juga termasuk sebetulnya neovaskular glaukoma yang kita pisahkan kriterianya karena sangat banyak jumlahnya. Juga ada sebetulnya afakik dan pseudofakik glaukoma yang bisa digolongkan dalam secondary glaukoma. Dan ini juga menunjukkan angka penurunan yang cukup drastis, ya, dia berwarna abu-abu di sini ya, jadi juga menurun, dan angka operasi terbanyak juga urutan ketiga adalah dari golongan open angle baik juvenile maupun POAG, dan yang keempat adalah pada pasien yang absolut glaukoma atau yang non functioning, tetapi di sini biasanya yang dilakukan surgery adalah non functioning tetapi ada rasa nyeri, jadi dolorosa. Sementara jadi kita mengalami dilema karena pasien tidak berkurang jumlahnya, atau maksudnya kasus-kasus tetap ada yang urgent maupun emergent, tetapi kita tahu dari rekomendasi yang sudah saya sampaikan sebelumnya ada keterbatasan ini, sehingga pada kesehariannya kita mengalami dilema, misalnya pada kasus-kasus suspek atau yang ocular hypertensif ini. Kalau zaman sebelum pandemi kita mempunyai luxury atau kita mempunyai kelengangan waktu untuk bisa melakukan close monitoring kapan saja kita rasa perlu. Tetapi saat ini kita harus pikirkan apakah pasien ini jangan kita monitor seketat sebelumnya, tapi kita juga takut ada resiko untuk progres menjadi suatu glaukoma. Maka seringkali kita mempunyai dilema dalam pikiran kita, apakah jadi kita mesti memberikan obat lebih awal, atau barangkali kalau misalnya kita dalam kondisi normal sebetulnya kita tidak akan mengobati selama kita yakin bisa memonitor secara ketat. Tapi karena kita tidak bisa memonitor lagi secara ketat, maka apakah jadi kita harus berikan obat-obat lebih early dari normally kita akan melakukannya. Nah, ini menjadi dilema. Kemudian untuk yang kalau dia tidak terkontrol, maka apakah akan kita lakukan operasi? Tetapi kita juga mengingat bahwa jumlah operasi dikurangi, dan kita bisa pilih harus yang lokal dibandingkan dengan general anesthesia, dan apakah kita memilih trabekulektomi atau tube atau pemasangan GDD, ini kembali lagi kepada rekomendasi kita. Apapun surgery yang kita putuskan akan kita kerjakan, sebaiknya kita pertimbangkan juga bagaimana follow up post-op-nya, apakah dia kira-kira membutuhkan follow up time yang lebih sering, maka tentu saja kita memilih apabila ada pilihannya untuk melakukan operasi dengan follow up time yang lebih kurang. Beberapa literatur mengatakan bahwa glaucoma drainage device ini ternyata lebih predictable, sehingga mungkin untuk kondisi pandemi ini akan menjadi lebih ideal, karena kita bisa mungkin tidak perlu serutin apabila kita melakukan trabekulektomi. Follow up time-nya atau post-op care-nya tidak seribet atau tidak bervariasi seperti pada post-op trabekulektomi. Jadi di sini merupakan pertimbangan apakah kita kemudian akan lebih prefer glaucoma drainage device. Jadi itu semua berpulang kepada surgeon preference-nya. Kemudian pada pasien-pasien yang stabil, kontrol baik dengan medikasi, apakah kita akan melakukan review sesuai dengan planning kita sebelum pandemi, barangkali 4 sampai dengan 6 bulan sekali kita akan lihat dan melakukan review tes Humphrey ataupun OCT-nya. Apakah kita bisa mengurangi pasien-pasien ini untuk datang di bulan-bulan tersebut, karena kita tidak tahu berapa lama lagi maraton pandemi ini akan berlangsung. Nah, di sini barangkali adalah kepentingannya kita mengembangkan suatu metode kontrol atau review yang lain. Dalam hal ini barangkali telemedicine, tentu dengan melibatkan jejaring atau kolega-kolega kita di daerah apabila pasiennya tidak ada di tempat kita dan berada di kota lain. Jadi ini adalah hal-hal yang mungkin kita bisa pertimbangkan dan kembangkan di kemudian harinya. Atau kita juga bisa mengutilize sesuatu teknologi yang sebelumnya kita belum terlalu banyak kerjakan, seperti trabekuloplasti atau micropulse fotokoagulasi. Hal-hal ini bisa mengurangi, menurut teori bisa mengurangi kebutuhan pasien untuk memakai medication atau menurunkan tekanan intraokular tanpa harus barangkali datang kontrol lebih sering. Jadi ini adalah hal-hal atau dilema yang secara mungkin harian saat kita melakukan praktek klinis kita timbul pada pemikiran kita, dan ini yang barangkali kita harus bantu selesaikan bersama. Jadi sebagai take home messages, saya mungkin menekankan lagi bahwa kondisi emergent dan urgent cases ini tidak berhenti dengan adanya pandemi, dan kita tidak bisa terus-terusan mengurangi pasien kita karena angka kejadian emergent dan urgent cases ini tetap sama atau bahkan bertambah. Dan kita membutuhkan adaptasi yang strategis untuk mengatasi kondisi ini dengan new normal, atau yang barangkali istilah barunya adalah adaptasi kebiasaan baru atau AKB. Kemudian yang menjadi prioritas tindakan adalah kita harus melakukan clinical judgment dan planning sebagai suatu approach yang case by case. Jadi barangkali satu kasus akan berbeda approach-nya dengan kasus yang lain, tetapi kita harus selalu mempertimbangkan keseimbangan individual patient risk untuk terjadinya kebutaan akibat glaukoma tanpa memaparkan risiko untuk terinfeksi coronavirus di rumah sakit atau di saat dia menjalankan treatment glaukomanya. Kemudian pasien ini berkurang karena memang kita melakukan active restriction sesuai dengan regulasi yang ada, tetapi di samping itu kita juga harus ingat bahwa ada juga pasien-pasien yang sebetulnya urgent dan emergent, jadi kita harusnya lihat, tetapi pasien tersebut yang takut datang ke rumah sakit karena takut tertular. Jadi dari kedua sisi ini akan terjadi pengurangan pasien yang datang ke kita, baik karena dia takut atau memang karena active regulation kita sendiri, sehingga di sini tentu saja kita harus hati-hati bisa meningkatkan angka kebutaan di tempat kita bekerja dan di Indonesia. Dan telemedicine di sini serta kolaborasi dengan jejaring rumah sakit yang ada di sekitar kita ini dapat membantu dan menjadi opsi untuk memberikan delivery care di masa depan. Sebagai penutup, mungkin ini sedikit saya tekankan lagi dari panduan pelayanan mata yang akan segera keluar dari Perdami. Ada jargon yang penting untuk kita ketahui dan selalu kita ingat dengan akronim CERDAS. C di sini adalah cegah resiko dengan screening pra kedatangan pasien. E adalah evaluasi ulang saat kedatangan di triase. R adalah regulasi ruang gerak semua pasien atau semua pengantarnya agar tidak terjadi infeksi silang. D adalah desain area untuk meminimalisir kontak dan kemungkinan risiko tertular. A adalah amankan kesehatan masyarakat, kesehatan mata masyarakat, dan S selalu ingat untuk kesehatan diri sendiri. Demikian, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr. Astrianda atas presentasinya yang sangat menarik dan sangat informatif. Bagi peserta webinar yang ingin bertanya bisa langsung menulis di kolom chat box.
I'm talking, so I'm mute now.
Kedengeran ya? Baik, kemudian kita lanjut ke pembicara kedua dari Prof. Naris Kitnaro. Prof. Naris adalah pengajar di Fakultas Kedokteran Rumah Sakit Siriraj Mahidol University Bangkok. Ini adalah CV dari Prof. Naris. Prof. Naris menyelesaikan fellowship glaukomanya di University of Heidelberg, Jerman. Kemudian dilanjutkan dari Bascom Palmer Eye Institute, Miami, Florida. Kemudian juga dari University of Tennessee Health Science Center dari Memphis, Tennessee, USA. Juga beliau telah menyelesaikan Master of Business Administration-nya. Prof. Nari juga member dari berbagai organisasi profesional internasional, antara lain Medical Council of Thailand, Royal College of Ophthalmologists of Thailand, dan AEO. Oke, Prof. Nari Skitnaro, please you can present your presentation.
Good morning. Good morning, everybody. First of all, I would like to thank the organizing committee for inviting me to join this. I think that this is very nice meeting. So, you know what? I really miss all of you guys because mostly we're gonna have the collaboration and meet in some meeting. But anyways, during the pandemic era, we can meet each other via online. This is my first time to meet you in, yes, online. So thank you, Dr. Estrada, for sharing the knowledge about how to manage your clinic in general, during the COVID-19 outbreak. So I would like to share my experience in Thailand during the COVID-19. And this is my financial disclosure. Okay, you know what? Thailand is the first country outside China who report the COVID-19 cases in January 8 this year. And after Thailand, the COVID-19 has spread all over the world. And luckily for the Southeast Asia, especially in Thailand, that we can control the outbreak of the disease very well. So I hope that in Indonesia in the future, you're gonna control the disease the same as in Thailand and in another country soon, very soon. Okay, this is the graph of the new case of the COVID-19 in Thailand. From the first case in January, so the case has increased the most during the March and April, and after that, the new case has decreased until now. We have only less than 10 cases a day. That's because of the campaigns that we can control the disease very well. So this graph is very important. That's because during the peak of the outbreak, the hospital has to be locked down too. In Thailand, all the hospital has stopped the service. We opened the hospital just only for the emergency case only. And you know that for the ophthalmology, it's not very emergency or urgency. So the case of the operation, we don't have to see the patients at outpatient during March to April. But after April, we start to come back and work again. But there is some lesson learned that I need to share with you how we cope with that situation. Recently, there is a report by WHO talking about the COVID-19 response in Thailand, and they conclude in some key success factors that you can learn from Thailand. The first one is the leadership of all the governments and the public health in Thailand. That's use the scientific evidence to cope with the outbreak. The second one is the administrative system adapt themselves to the pandemic very well, from the public health to the government. So there are so good collaboration between we call the public health in the village. So every village will respond to the COVID-19 very well. And there is Thailand has experience before about the outbreak of another disease such as H1N1 or influenza before. And since the first case that we detect in Thailand, So we have the screening campaigns and system from every door of the country, both the border and the airport. So with the good screening, so we can detect the new case and we can follow the suspicious patients all over Thailand. And one of the things that Thailand is an example of the culture that we always not contact with another person. So when the way that we greeting, we use why. That's always keep away from each other. That's a good point during the outbreak. And you know what? The whole society responds very well to the outbreak. That is one of the important factor that we can control the disease. And this is the picture of this is our Prime Minister. And you know what? This is a committee of the public health. The Prime Minister invite at least half of them are my teacher. So the Prime Minister believe in the doctor that cope with the pandemic before. And Thai people, you will know that Thai people always has their own freedom. But during the COVID-19, they strongly believe in the public health administration. So they one that we have the campaign to put the mask on. Everybody put the mask on. And this is a way that we greeting, we call why, that we don't touch each other. This is one of the factors that many countries learn from Thailand. And how about the COVID-19 in ophthalmology? I want to stress on how important that in ophthalmologists need to know about the COVID-19 outbreak, because the first doctor in this world who died from the COVID-19 was the ophthalmologist. And I have just known that the first doctor, the ophthalmologist who died from the COVID-19, he is the glaucoma specialist. There are some factors that ophthalmologist is a high risk of receive the disease. That's because the way that we examine the patients is very close to each other. Our face and the patient face is very close. That's why ophthalmologist is a high risk doctor who are prone to get the COVID-19. So for the ophthalmic manifestation, in the animal model, the COVID virus can cause a severe ocular disease such as anterior uveitis, retinitis, vasculitis, or optic neuritis. But very lucky, the ocular manifestation of COVID-19 in human eyes are very rare. The latest report is caused only 0.8% of the 1,300 cases in Wuhan patients. So the most common manifestation is a conjunctival congestion or hyperemia. You can call the conjunctivitis, but it is not very common in the COVID-19 patient. So you have to be aware that most of the cases in your clinic might have the COVID-19 without any ocular manifestation. And another side of the COVID-19, especially in the advanced case, I don't think that ophthalmologists will face with the very severe COVID-19, because most of them will be admitted in the hospital. So another ocular manifestation include of the chemosis, epiphora, or sometimes increased eye discharge, but mostly they have the watery discharge. And very lucky for us that the ocular secretions is rarely has a COVID-19 positive. But anyway, the most important media that can spread to us is the tear. You have to remember that the human tears might have the COVID-19 virus in that. So during the pandemic area in Thailand, we stopped using the pneumatic tension, because every time that you put the air pump into the eye of the patients, there is an aerosol of the tear spread away all around the examination. So during the COVID-19, it is very strict not to use the air puff to check the eye pressure. Another signs and symptoms of the COVID-19 patients mostly is eye redness, ocular irritation, foreign sensation, foreign body sensation, tearing, and chemosis. And some cases, if they present with the follicular conjunctivitis, you have to differentiate with the EKC, because mostly EKC will have follicular conjunctivitis. But I don't think that in our practice we have the COVID-19 patient presents as a first presentation with us, and there is no report up to date that the patient with COVID-19 has a blurry vision or subconjunctival hemorrhage or chemosis or something like that at all. So it means that you have to be aware that if the patients with the high risk situation, such as coming from another country, may be infected with the COVID-19 and present with the conjunctivitis, you have to be aware that patients might have the COVID-19. How about the treatment of the COVID-19 ocular manifestation? There is no specific treatment. There is no recommendation to use even with the steroid to treat the conjunctivitis. So they recommend to use just only tears or antihistamine only, and mostly it will be self-limited. So how about to manage the ophthalmic clinic in your practice? In Thailand, okay, so after we talk about this topic, you can realize that the risk of the virus transmission to ocular secretion is very low. But anyway, you have to be aware, because we have to touch the patient eyes, and if you keep the secretion get into your eyes or around your face, it will be very harmful that you can infect it from that secretion too. So the routine ophthalmic patients are delayed. So Dr. Estrada has recommended already that we should see the patient just in case of emergency or the important disease only. So new patient that's referred to your clinic must be seen by the local doctor and determine if the patients need the urgency consult to you or not. If it's not, you can delay that case to the period that the pandemic is controlled. And the chronic stable patients, such as the glaucoma patients, that's already controlled. You can re-medication via the telemedicine. The problem is that, is there any facility for the telemedicine in some area or not? Okay, this is our OPD. So we have the sign. This is, you can sit, but you have to keep the social distancing at least 60 centimeters or 1 meter away. So you know what, the waiting area in OPD or in operating room in Thailand, we always have this sign on the seat, which where the patients can sit, and this place you cannot sit. And there is alcohol gel all over the place in Thailand, in the hospital, in the department store, to dispense with the alcohol gel and to get rid of all the secretion. That's my cause. And we also have the ultraviolet robot. This robot is very smart. They can go to everywhere in the hospital, but they cannot use the elevator, okay? So they can go to everywhere and use the ultraviolet to clean the virus everywhere in the hospital. So in the future, it might be important. And one of the important that you have to have is the temperature, the body temperature screening to every patient. So they screen for the fever, and also to check if the patient has another sign of the COVID-19 or not. In case that there is something wrong with the screening point, the patient asks to go back to their homes. So it will be stop the risk to spread the disease to another people. And if they have the history of the foreign travel or transit to another place with the risk area, they have to ask not to go to the hospital. And if they have the history to contact with the suspected people with the COVID-19, so all these cases need to be not to go to the hospital. Okay, so one of the things that is very strictly in the hospital is to wear the mask everywhere, both the patients or the relatives. Everybody in the hospital need to wear the face mask. There is a research that for the face shield, it is not as safe as wearing the face mask. Okay, for the gloves, in Thailand it is controversy because once that you wear the gloves, you can touch everything and you are not aware that the glove is dirty. So in our hospital, it's not recommended to always wear the gloves because sometimes it's cause more dangerous to the patient and to yourself. And as I said that we always wash hands and use the alcohol gels every time. Okay. And at the slit lamps, I think that this is the innovations that you really need, that you need the slit lamp here that's made from the acrylic sheet. It is not very difficult to use this one, okay? You can put the sheet between doctor and the patients, and you have to ask the patient to wear the mask every time that you check the eyes. And in some area that you don't have the acrylic sheet, you can use the old X-ray film. But nowadays, we don't use the X-ray film anymore because we use the X-ray and transfer it online. Okay, this is one of the important that you need it in your clinic. The problem is that once you use the mask and the shield, sometimes there is a foggy at the eyepiece, so it makes us more difficult to examine the patient's eyes. And I use the non-touch technique. You have to practice how to use the cotton bud or cotton tip to open the eyes and check the eye pressure. And you can see that keep away from touching anything on the patient face is very important. And try to talk less, okay? And if you need to talk, you have to get away from the patients and always clean all your instruments with at least 70% ethyl alcohol. And there are so many innovations in Thailand that's happened. We have to check in and check out at the clinic because once that the doctor or the patient has the COVID-19, we can alert to everybody who check in and check out at the clinic. And this is a COVID map. The COVID maps in Sirat Hospital, we will know where does have the report of the COVID patients. So in that, the place that has a COVID reported, it will turn from green to red. So the patients, the people can get away from the place that there is a report of the COVID-19. And Sirat has a Sirat Connect application. That's we use this one as a telemedicine. So in the non-communicating disease that is stable, like the hypertension, diabetes, even with the glaucoma, we can see the patients via the telemedicine from the mobile application. And you know what? During the operation, this is one of my friends, because during the phacoemulsification, there is an aerosol from the eyes coming out from the patient's eyes. So they use the plastic bag to cover everything, and it can prevent the aerosol from the operating area get into the doctor or all the personnel in the theater. But nowadays we found that it's not very easy to use a plastic bag to cover everything in the theater. So just only the suspicious case that we have to do something like this. And one of the important thing that is very useful is the medicine delivery. You have to find a way how to send the eye drops to the patients without seeing the patient in real. So you have to have the telemedicine with the delivery, something like this. So in conclusion, our country has success with the number of the COVID-19. So in Ceylon Hospital, we have only 200 cases of COVID-19 for the whole 8 months. And there is no ocular manifestation of the COVID-19, and ophthalmologists had never ever take risk with the COVID-19 patient at all during the 8th month. But the ocular shading of the COVID-19 where the tear is possible. So we have to be aware about this risk too. Conjunctivitis or tearing can be the first presentation of the COVID-19. So I hope that in your country, you will not the first line of the doctor to see the patients with the COVID-19. And besides the conjunctivitis, that is the most common. The patients can present with chemosis or follicular conjunctivitis. That is very common presentation of the EKC in Thailand. I don't know whether it is common of the EKC in Indonesia or not. But once that you have the patient with follicular conjunctivitis, you have to differentiate diagnosis with the COVID-19 patients as well. The ocular examination should be performed avoiding direct contact. And if you practice to use instrument to open the eyes, to clean the instruments, it will be safe to ophthalmologists. Social distancing, wearing the mask is always, that is very important. And we have proof that wearing the mask is one of the factors to control the spreading of the COVID-19. The physicians most at risk, you can see that ophthalmologists, ENT and anesthesiologists are the most at risk. That's because we must to see the patient, we must see the patient very close to the mucosal or with the breathing. So be aware to prepare for the COVID-19 outbreak. So the key success in Thailand, you have to give the information to the public about how to prevent the COVID-19. In Thailand, protecting health workers, especially with the doctor, the nurses are the most important in Thailand. So all the patients, all the people try to give us every facility to prevent the health worker. So detecting the new case, you have to have the big screening to the suspicious people who might have the COVID-19. The strengthening of the workforce, both the public health, local health worker, until the government is very important to fighting with the COVID-19. And as I told you, if you go to Thailand, visit Thailand, you have to stay in the quarantine. We call the alternative quarantine. That is a 5-star hotel in Thailand, in Phuket, in Chiang Mai, in many tourist destinations. Why? Because you have to stay there for 14 days. But during the quarantine, you are happy because you stay in the world-class quarantine hotel. Okay. And one of the important things, you have to enhance coordination from the bottom to the top to fighting with the COVID-19. And I hope that in Jakarta, the situation of the COVID-19 will be controlled the same as in Thailand soon. And you know what, in Thailand now today, we almost have the normal activity. So we stop doing the eye surgery for only, I think that's 2 or 3 months only. And now we start to do the operation the same as before. And the number of the operating case go to normal. That's why if you control the outbreak in your country very soon, the patients will get the treatment the same as before the outbreak. Thank you very much for for this session.
Okay, thank you, Prof. Haris. We can proceed with the next presentation, the second presentation, please.
Okay. So if you have any questions, you can ask me later, right?
Yeah.
Okay. For the next presentation, I thought that during the COVID-19 outbreak, the number of the case with give me a second. So during the COVID-19 outbreak, So during the COVID-19 outbreak, I guess that there are many cases with the ankle closure that you have to cope with. And there are many acute ankle closure in my department during the COVID-19 outbreak. That's because we cannot perform the standard treatment for the ankle closure. The first one is for the ankle closure, you need to do the standard treatment. That is iridotomy. But during the COVID-19, we cannot perform the iridotomy as regularly. That's because it's claimed that once you do the laser, it's very risk for you to get the secretion into the aerosol or the instrument that you use with the contact lens. So the number of the case with the acute ankle closure is forecasted to be increased during the COVID-19. So I need to talk about the surgical option for the ankle closure. Okay. Normally, we try to do the peripheral iridotomy as a primary treatment, initial treatment for the ankle closure. But now today, doing the peripheral iridoplasty, especially in acute ankle closure, is another option to break the acute ankle closure. And with the laser peripheral iridoplasty, you can use the less power, and it can cause the less complication, especially with the corneal trauma. So during the acute ankle closure, it is recommended to try to do the peripheral iridoplasty first, and after the eyes is under control, the pressure, no corneal edema, you can try to do the peripheral iridotomy later. One that you try to do iridoplasty and iridotomy already. Another option for the surgical treatment for the ankle closure. The first one that I would like to persuade or convince you to do is to do the lens or cataract extraction. Why we have to do the cataract extraction? In my opinion, so you have another option, like in ankle closure, you can try to do the cataract extraction first. And if the pressure cannot be controlled, you can consider to do the cataract, to do the glaucoma surgery later on. I love to use this option because to do the cataract extraction is, I think that's in a good hands. It is not very difficult, but there are some challenging factors you have to be aware to do the cataract extraction in ankle closure. And after cataract extraction, if the disease cannot be controlled, we can consider to do another filtration surgery. And if you do the filtration surgery first and followed by the cataract extraction, sometimes cataract extraction disturb with the filtration breath. So for the second option, I don't like to do this option very much. And to do the combined surgery, you know what? There are many reports that combined surgery has less successful because if you do the combined surgery, both cataract extraction and glaucoma surgery at the same time, there are many inflammation. So the breath survival is less than if you do separately. So why we have to do the cataract extraction alone in PACT? Because you can avoid the thoracolectomy complication, both the infection, the thin of the blood, and the tearing or something like that. And there is many research about the quality of life of the patients without the blood. The quality of life is better. The patient doesn't need to use another medication even with the tears. So you can consider to do the cataract extraction alone in the PACT with the medically control or with the early stage of the disease. But to do the cataract surgery has many challenging factors because the patient might have the high IOP. You have to reduce the eye pressure before the surgery. And there is a shallowness of the anterior chamber. If you cannot control the chamber during the operation, you have to be aware because the rate of the complication is higher. It can cause the cloudy of the cornea even during the operation because the corneal quality of the patient with ankle closure is compromised. So sometimes you will find the difficulty of the visualization during the operation. It can decrease the corneal endothelial cell count. And finally, you might to face with the floppy eyelids during the operation. And there is the posterior synechia, the bulky of the lens, the relaxation of the lens sonus, and the high risk of the malignant glaucoma even during the operation. This is a thing that you have to be aware during the cataract surgery. Okay, this is why the cataract surgery is good for the ankle closure, because one that's after the cataract surgery, the ankle is opening. And recently, there is a research that just only with the cataract surgery only, the PAS of the ankle is reduced without anything. You don't need to do the goniosynechial lysis, but the PAS of the ankle is decreased without the goniosynechial lysis. So that's why in some literature they compare the eye pressure after the cataract surgery alone and cataract surgery and TSL. And they found that with the cataract surgery alone, both the IOP, the ankle is wider opening, and the PAS is less without the TSL too. Okay, so there is a randomized control trial to compare between doing the laser PIs and use the medication alone and to do the phacoemulsification. And they found that doing the phacoemulsification is more effective to reduce the IOP, and it can reduce as high as 55 millimeters lower IOP down from the pre-operation. So in this paper, it is recommended to do the phacoemulsification in the ankle closure. And how about to do the crystalline extraction? Sometimes you know what, when the patient has a glaucoma, when the patients get the aging more than 50 years old, they start to have the cataract. So in case that they have the PACT, and even with the low pressure, you can try to do the crystalline extraction. There are many benefits from doing the cataract extraction even without the dense cataract, because it can reduce the pressure, and also they can prevent the progression of the PAS too. Okay. And so that's why the EAGLE study is recommended to do the laser PIs no, the cataract extraction in case of the PAC or PACG. Okay, so there are so many research that's claim that doing the lens extraction is good even with the cost effectiveness, because in 3 years they don't need to use the eye drops even with the tears. So in the long term, it's good to have the cataract extraction. In case that after the cataract extraction and the pressure cannot be controlled, you can try to consider to do something else, such as to combine with the goniosynochialysis. I am really surprised that some doctor perform the goniosynochialysis after cataract extraction. But Dr. Mori in Japan, he does the TSL before the cataract extraction. So I asked the reason why he performed the TSL before the cataract extraction. He said that's because of the corneal edema. So if he performed the TSL after the cataract extraction, sometimes the corneal edema is extensive until the visualization is not good to do the TSL. So in my case, I thought that if the cataract is not that very dense, we can do the TSL after remove of the lens. It will be, I mean, I thought it's easier to do that. Okay, and how about to do the combined phacoemulsification and GSL in uncontrolled chronic ankle closure? In one of my research that I did with the Singapore team, we found that in the chronic ankle closure, GSL is not very useful to reduce the number of the medication or even with the eye pressure. So in chronic ankle closure, you can consider to do just only the cataract extraction. That is enough to control the disease. Okay, and but anyway, the phacoemulsification with GSL will be very useful if you do this kind of the procedure in the post-acute ankle closure. And you have to try to the GSL and phaco within 6 months after the attack. It will be very useful. Okay, this is my research with Dr. Hussein in Singapore, and we found that the GSL, phaco GSL in chronic ankle closure is not, I mean, significantly reduce the number of the medication or the IOP. So in the chronic case of the PACG, you don't need to do the GSL. So we try to explain why the GSL in chronic ankle closure is not very useful. We found that it may be because of the permanent damage of the trabecular meshwork that's too long. So after the synochialysis, the function of the trabecular meshwork will not come back and perform the IOP reduction anymore. So GSL is not recommended in the chronic case, but we recommend to do it after the acute ankle closure within 3 months. And you have to be aware that GSL can cause the intraoperative hemorrhage. In some recommendation, they say that the minimal hemorrhage during the operation is a good sign of the GSL. That means that we can truly reduce the synochia. And if there is no a little hemorrhage, sometimes the synochia is not that enough lysis. Okay. So how about to do the trabeculectomy in ankle closure? It is proof that trabeculectomy can reduce the pressure better than to do the phacoemulsification alone. But anyway, to do the cataract, to do the trabeculectomy can cause the more complication, especially with the long-term complication. And how about phacoemulsification and combined phaco trap? Okay, so you can guess that combined phacotrabeculectomy can cause lower of the eye pressure and the number of the medication. But anyway, they have more complication. And how about the glaucoma drainage devices? You know what? You have to perform the cataract surgery before to insert the tube into the anterior chamber. If you, you know what, at the early period, I insert the tube into the anterior chamber in ankle closure without the cataract surgery. So the anterior chamber is very limited. And finally, the tube that close to the lens cause the cataract, and the tube that close to the cornea cause the corneal decompensation at finally. So it is recommend if you need to do the TDD in PSCT, you have to perform the cataract surgery first. Okay, how about the express implantation? It can, okay, it will be okay to do that, but anyway, with the express, it will be close to the cornea compared to the open angle. So you have to, it is recommend again to do the cataract surgery first before use the express. And now we are in the minimally invasive glaucoma surgery. I have to tell you that just only one series that's used the eye stent that perform in the ankle closure, and they perform in only 37 eyes with PACT, and they found that the eye stents with the cataract surgery can lower the IOP and the number of the glaucoma medication, but only at the first 12 months. We have to wait for the mix in ankle closure in the long term to see if it is work or not. So in my opinion, I thought that for the mix, now today the result is compromising. So I'm not into the mix at this period. I thought that they still need to see the long-term efficacy more. And how about the cycrophotocoagulation? You can combine the phaco with the ECP or endoscopic JSL, but it's cause with the ECP, it's cause less inflammation. But anyway, with the phacoemulsification alone, it can lower the eye pressure. So we need to compare with RCT whether the cycrophotocoagulation or ECP is very useful or not without the cataract extraction. In conclusion, the surgical option for the PACT has many, but only the early lens or cataract extraction, trabeculectomy, and goniosynovial that's now today has a RC3 randomized control trial to prove that those three surgery can lower the pressure and the number of the medication comparing to the cataract surgery alone without compared to the laser PI alone and medication. That is better than laser PI and the medication. And in the future, we need the RCT for the TDD, for the mix and phaco ECP to prove that it's very useful to the ankle closure patients. Okay, so this is a surgical option for the ankle closure. And I would like to say that during the COVID-19 pandemic era, you will face with more case of the acute ankle closure because we have to stop doing the phaco cataract surgery and we cannot perform the laser PIs as regularly. So in the future, we're gonna have the more case of the acute ankle closure. Thank you very much.
Okay. Thank you, Professor Naris, for your very interesting and informative presentation. Now we come to the discussion session. Dr. Astrianda has already answered the question from the chat box. And for you, you have two questions in the chat box from Dr. Evelyn Komarati. She's also a glaucoma specialist. What is your prediction regarding the number of glaucoma patients who did not properly manage during this pandemic? What should we do? Because as we all know that this pandemic has created unwanted barrier for patients with chronic diseases.
Give me a second. So the question about the phacomorphic glaucoma, right?
What is the prediction? Because many glaucoma patients did not properly manage. So the number of glaucoma patients maybe will increase. What should we do?
You know what? This is the question that we always ask during that we stop our clinic in Thailand. But with the telemedicine, so in cases we have the new case, we have to ask them to consult with the local doctor first. And in cases the patients really need the treatment, that patient needs to go to the hospital. And with the screening of the COVID-19 with the nasal swab or the throat swab, something like that, it needs to be done at least 3 days before arriving at the clinic. So I thought as first one, we have to control the outbreak of the COVID-19 as soon as possible. And the second one, we have to try to come back to our service to prevent the acute ankle closure with the laser PI, or even to perform more of the phacoemulsification, something like that.
Yeah, but you know, in Indonesia, now the situation has not control. The new cases keep rising every day.
Yeah, that's the problems. That's the problems. So it's hard to say. And you know what? I don't want the ophthalmologist to be at risk with the COVID-19 because we can receive the disease, and also we can spread to all the another patients too. So with the ankle closure, I thought that's finally we have to do the laser PI. That the less risk of the procedure that we can consider during the pandemic era like this. And with the laser PIs, I thought that is less risk to have the aerosol spread into our nose or face, something like that. And you have to prevent yourself with the mask, with the face shield, with the glove and everything. Yes, it's hard to say, but I would recommend to try to do the laser PI.
Okay. And do you think the number of glaucoma patients, do you think will increase in the future then because of this pandemic?
Yes, absolutely. That's because we cannot do the cataract surgery.
Okay. Did you do all that the preventive devices?
Yeah, another question from Dr. Aritika, and yes, she said that there is a phacomorphic glaucoma patients with uncontrolled IOP and with two medication, and she got the COVID-19 positive without symptoms about 6 weeks ago, and she came with the mature cataract. And you know what, with the phacomorphic glaucoma, you cannot control the disease without cataract extraction. So this is a secondary acute ankle closure. You have to get rid of the primary cause. So whatever, you have to do the cataract surgery. And because she has a mature cataract, if you still wait without the cataract surgery, finally she will come with maybe the absolute glaucoma finally because of the uncontrolled IOP, or the phacolytic glaucoma that can cause the permanent damage to the trabecular meshwork. So I would recommend to try to do the cataract surgery as soon as possible. And it is recommended that for the patients with the COVID-19, they have to check for the virus until there is no positive, until there is a negative of the COVID-19 culture. During the meantime, with the phagomorphic glaucoma, you can try to do the laser PI. If you can do it, if the anterior chamber is not very shallow. But finally, you have to do the cataract surgery as soon as the COVID-19 culture is negative.
Okay. One more question from Dr. Rini Sulastiwati. How do you manage patients that come to your outpatient department that need ophthalmic care, such as their sequential intravitreal injection or maybe needling? What are the examinations would you order? Do swab, X-ray, labs are routines for clean room cases?
So
Can
you know what?
check?
Yeah. So you know what? So this is a regular practice in Siloam Hospital during the pandemic period that has many cases of the COVID-19. Every patient need to do the throat swab of at least 3 days before any procedure. In case, luckily that there is no case that is positive in our department. So if the throat swab or nasal swab is negative, the patients can have any kind of the operation procedure in Siloam Hospital. Okay, so it is very important for Indonesia at this period that you have to do the screening test at least 3 days before the operation. And in cases the patient has a risk factor, such as they have just come from the area that has a COVID-19, in this kind of the patient, they are not allowed to have the operation for at least 14 days, because 14 days is recommended for the quarantine period before the operation or going out without any protection, something like that. So there are two numbers: 3 days before the operation for the non-risk patients and 14 days for the patient with the risk factor.
Okay.
And regularly in Thailand, we do not do the chest X-ray for the screening of the COVID-19, because chest X-ray has been changed later. I mean, it's not as fast as the throat swab, because many cases of the COVID-19, there is no symptom with the normal chest X-ray. With the collaboration with the Alibaba and Huawei, in Thailand we have the CT X-ray, the chest CT X-ray with the AI from the Huawei and Alibaba that they give us for free. And in cases we suspect the patients very much about the COVID-19, we're gonna do the CT of the chest CT and use the AI to see if the patient has a little bit of the haziness of the CT of the chest or not. In that case, it can detect COVID-19 earlier than the chest X-ray, the normal chest X-ray. So it is not recommended to do the chest X-ray as the primary screening test for the COVID-19.
Okay. So no need for X-ray, okay, and that routine.
No, in Thailand we do not do the routine chest X-ray as the screening test for the COVID-19.
Okay. What about now in Thailand the situation is good. There is no
Very good.
Yeah.
Very
So
good.
how is your equipment protection device? What you usually regularly use now? Is the same before?
Now, yes. As I show you, we have the shield, right?
Yeah.
Do you have the shield at your clinic?
Yeah. You mean in the slit lab?
Right.
Oh, screening. Yes, screening. We have a screening.
Yeah. So it is very easy.
Hospital.
Yeah. And we use a face mask and alcohol. So just a regular thing that's very important to protect yourself. But anything else is that the screening point since the patient step into the hospital. At the entrance of the hospital, there is the screening points everywhere. So the patients, before they get into the eye clinic, they have to be screened at least 4 points. So that's a lot. So sometimes you have the sticker on the shirt for four sticker. That's because you have passed 4 checking points.
Oke. Dokter Astrianda, semuanya udah dijawab ya?
Sudah, Dok.
Dan Dokter Lydia itu sudah?
Mana deh, kok nggak ada sih? Mana Dokter
LN.
Lydia? Ada Dokter Lydia? Mana?
Untuk saya, untuk
Di bawah
Oh, ini
Aryatika.
ada ya?
Iya, Dokter LN.
Dari Dokter Aryatika. Oh ini. From Dokter Lydia. Prof. Naris, outpatient clinic diagnosed acute glaucoma with glaucoma therapy and swab result positive COVID. How to manage it? From Dr. Lydia.
Ini ada lagi penjelasannya, Dok.
Gimana sih?
I mean glaucoma.
From Dr. Lydia.
Lydia, LN.
See, so okay.
Glaucoma acute couldn't respond with glaucoma therapy. What should we do with positive COVID?
So you know what, to do the cataract surgery. I am into the cataract surgery with the acute ankle closure. So the first line, you know what? Last week I have 2 cases of the acute ankle closure. So the pressure was 50. The first thing that I did is to do the paracentesis. Okay, with the 30 gauge needle, and the pressures come down to 18. So once you perform the paracentesis, it's the golden period. Once the pressure is low, you have to do the laser iridoplasty. Okay, so once you do the paracentesis, the pressure going down, the cornea is clear. You have to do the iridoplasty first, and then you control with the medication and follow up the patient on the next day. If on the next day the pressure is very good, you can do the laser PI. And if the pressure is still high, I will do the paracentesis and cataract surgery.
Okay. With swab positive of COVID-19, this patient has.
With the COVID-19, you know what? I have never had the COVID-19 positive patients. So with the COVID-19 positive patients, I will delay, but to do just a laser procedure only. All kind of the surgery that can expose to the nurses, to many people. I would try to stop the risk of the disease to get into the medical personnel. So just to do the laser iridoplasty, paracentesis, and laser PI. That's it. And wait to COVID-19 to be controlled. I mean, if the COVID screening is negative, so this kind of the patients might need the surgery later on. Don't be rushed because your people are very important. You have to protect your people too. So it is not worth to take risk with just only one patient and then get the disease to another medical personnel, and it can spread to another patients too.
Okay, we have to postpone. Next question from Dr. Aryatika Alam. Phacomorphic glaucoma patient with uncontrolled IOP with 2 medication, beta blocker and acetazolamide. Previous COVID-19 positive without symptoms. 1 month ago, she came with mature cataract, but after screening for COVID-19, found to be positive. The operation was postponed. After 3 weeks, she came with phacomorphic glaucoma IOP 37 to 40. This is almost the same as Dr. Lydia's questions. Yes, Prof.
Yes, I thought I did answer that question. Yeah. So I hope that the COVID-19 in especially in Jakarta will be controlled very soon. Okay. In case there is an outbreak, try to visit Thailand, because in Thailand we are very safe. I will prepare the world-class quarantines hotel for you guys.
For this question, the same answer with Dr. Lydia's questions?
Yeah, with the phacomorphic glaucoma, right? At least you finally you have to do the cataract surgery, but you have to wait until the COVID-19 swab is negative, at least 3 days before the surgery. And during the surgery, you have to invent the plastic bag to cover the patient eyes during the operation. Okay, because there is the report that during the phacoemulsification, the aerosols that come from the phacos has spread all over the room. If you have the room with the size 6 meters by 6 meters, all the room will fill out with the aerosol from the patient eyes. So you have to invent the plastic bag to cover the patient eyes to limit the spreading of the aerosol from the phacoemulsification. That is very important.
Okay. Thank you, Prof. Nadis. I think there's no more question. Dr. Astrianda mau nanya satu. Kalau di Jakarta di RSCM semua pasien di swab.
One questions from Dr. Henry.
Oh, apa lagi?
Yes, he asked why you do iridoplasty instead of laser iridotomy. Okay, so you know what? To do the iridoplasty is very easy. Very easy. You don't need the clear cornea that much. So iridoplasty, you use the less power, and you don't need very clear cornea. So it is recommended for the patients with the acute closure, in case that you think that you cannot do the effective laser iridotomy, you can try to do iridoplasty first and see if the eye pressure can be controlled and the cornea is clear or not. And you can delay the laser iridotomy later, maybe on the next day or the next week, and you will find that it is much easier to do the laser iridotomy in the cold eyes. I call the cold eyes. And if you do it during the hot eye, like a very inflamed corneal edema, microsis, high pressure, you have to put more power So in the future, this case of the patients might have the corneal decompensation finally. So I would recommend to try to do the paracentesis or use the medication such as the diamox oral glycerin before to lower the pressure, and do the iridoplasty followed by the laser iridotomy. And in cases the disease cannot be controlled with the cold eyes but high pressure, I will try to do the phacoemulsification finally. And it is not recommended to do the glaucoma surgery in acute ankle closure because the failure rate is very high, especially with the trabeculectomy. So I would not recommend you to do the trabeculectomy in acute ankle closure. You have to stabilize that inflamed eye first. Lower the pressure, no eye inflammation. So after that, you can consider to do the glaucoma surgery.
Okay. Thank you, Prof. Naris. I think we don't have any more questions. Cukup ya, Dr. Firna? Udah?
Yes,
Okay.
Dr. Elsa.
Astri? Okay, Dr. Astrianda and Prof. Naris, thank you very much for your presentation today. Terima kasih banyak atas presentasinya. Semoga memberi manfaat pada kita semuanya. Atas nama seminar dan panitia, kami ucapkan terima kasih kepada semua yang terlibat, dari panitia, dari Dr. Fitratul, dari sponsor, dan seluruh yang ikut serta aktif dalam webinar ini. Sebelum ditutup, mungkin mau difoto dulu ya?
Terima kasih.
Ya, baik. Ya, terima kasih untuk moderator. Baik, silakan para peserta, kita akan on cam untuk foto bersama. Silakan. Silakan yang mau gabung untuk peserta. Baik, kami tunggu 10 detik untuk on cam agar kita bisa berfoto bersama. Silakan.
We will take picture, Prof. Naris.
Thank you. Ya.
Ya, baik. Silakan. Baik. Untuk yang sesi pertama, silakan lihat ke depan kamera. Kita mulai hitungan 1 sampai dengan 3. Senyum semua, smile on your camera. Yes. We'll take 1, 2, 3. Okay, next. Baik, hitungan ketiga. Lagi senyum, smile. 1, 2, 3. Okay, next. Baik, hitungan ketiga. 1, 2, 3. Baik. Lagi 1, 2, 3. Baik, 1, 2, 3. Yang terakhir, senyum semua, smile. 1, 2, 3. Baik, terima kasih. Saya kembalikan ke moderator.
Thank you, Prof. Kitnarong.
Thank you. It is very nice meeting. Very exciting and very, I think that it's very good arrangement. Thank you.
Thank you very much.
Thank you, Prof.
Very nice. And I hope that to see you guys in real very soon somewhere in Indonesia or something like that.
Yes, hopefully. Thank you, everyone. Thank you.
Terima kasih, Dr. Astrianda.
Terima kasih semuanya.
Until the COVID case.
Dr. Elsa, terima kasih.
Terima kasih.
Terima kasih.
Acara ini ditutup ya. Terima kasih. Assalamualaikum.
Dr. Firna.
Warahmatullahi wabarakatuh.
Terima kasih, Dr. Yulia. Semua peserta terima kasih.
Sampai ketemu.